Welcome to your custom deep dive. Today we are exploring the critical clinical protocols surrounding neonatal jaundice, our mission, to unpack exactly why newborns turn yellow and how to safely treat it. Let's unpack this.
Yeah, thanks for having me. It's honestly one of the most astonishing, high-stakes physiological processes a human being will ever go through.
It really is. Imagine taking your first breath, entering the world, and then, within 48 hours, your own body starts poisoning your developing brain.
Right, with the recycled remnants of your own blood, no less.
Exactly. And for, 80% of premature babies, this isn't a horror movie. It's just biology.
It's just a Tuesday in the NICU, yeah. And when you really examine the clinical protocols and the underlying biochemistry of it all, you realize just how delicate that margin for error really is in those first few days of life.
Usually when we talk about a medical diagnosis, there's this expectation of, binary precision, like a broken bone. The X-ray shows a jagged white line, and the doctor just points and says, there it is, broken.
Right. Very cut and dry.
Yeah, but then you step into the clinical landscape of neonatal jaundice, and suddenly you're dealing with a situation where the visible symptom is incredibly common, like almost ubiquitous.
Yeah, affecting roughly 60% of term babies and, like you said, 80% of preterm babies.
Right. But despite it being so common, the underlying risk is absolutely catastrophic.
Yeah.
So to really understand this, we need to define exactly what the clinician is looking for when that warning light goes on. The word jaundice itself comes from the French word jaune, which simply means yellow, right?
Yep, that's right. And clinically, it presents as a yellowish discoloration of the skin, the sclera, which is the white part of the eyes, and the mucous membranes.
Okay, but that color change doesn't just happen the exact second the baby is born, does it?
No, not at all. The visible yellowing only occurs when the hyperbilirubinemia, that's the excess bilirubin circulating in the blood, when that reaches a very specific threshold.
Which is what?
Serum levels of about 5 to 7 milligrams per deciliter.
Okay, let me make sure I'm picturing this correctly. Why 5 to 7 milligrams? And why do we see it in the eyes first? I always assume the skin would be the most obvious indicator since there's just so much of it.
It's a good question. It all comes down to the microscopic affinity of bilirubin for certain types of tissue.
Okay.
Bilirubin has a remarkably high affinity for elastin tissue, and the sclera of the eye happens to be, well, incredibly rich in elastin.
Oh, interesting.
Yeah, so before the concentration in the blood is high enough to noticeably saturate all the fat and skin tissues, the bilirubin binds really tightly to the whites of the eyes.
So the vigilant clinician or even a parent will catch that faint yellowing in the sclera first.
Exactly. That 5 to 7 milligrams per deciliter mark isn't just a random number. It's nature's earliest, most sensitive visual alarm bell.
It's quite literally a dashboard warning light.
Right.
The yellowing isn't the disease itself, right? It's the indicator that the internal, oil pressure, the bilirubin, is running dangerously high.
I like that analogy.
And if that pressure gets too high, it threatens the engine, which, in a newborn, is the developing brain.
And that is the crux of the entire clinical protocol. While a yellowish hue to the skin might seem like, a harmless cosmetic quirk to an untrained observer, the danger lies in the profound toxicity of bilirubin to the developing neonatal brain.
Which is terrifying.
It is. This toxic state is broadly referred to as kernicterus, and it is the most dangerous, devastating complication of jaundice, period.
How does it actually damage the brain, though?
Well, when unconjugated bilirubin circulates freely at high enough levels, it actually has the chemical ability to cross the blood-brain barrier.
Oh, wow.
Yeah, and once it's inside the brain tissue, it causes permanent, catastrophic neurological damage. It is a clinician's worst nightmare.
And yet it affects 60% of term babies and a staggering 80% of preterm babies. If 80% of premature babies get this, it almost feels like a default setting rather than a glitch.
It really does.
Why is the human infant so uniquely prone to this? Why are we built to generate a brain-damaging toxin the very moment we are born?
To answer that, we really have to look under the hood at the body's recycling plant. We need to look at how this toxic substance is made in the first place.
Okay, let's trace the biochemical assembly line.
Sure. So the production of bilirubin is actually an ongoing, totally normal physiological process. It's a direct byproduct of degradation.
Degradation of what, exactly?
Specifically, 75 to 80% of bilirubin is derived principally from the breakdown of hemoglobin. That's the protein inside red blood cells that carries oxygen.
Okay, so 75 to 80% comes from old or broken down red blood cells.
Yeah.
That makes sense. But the remaining 20 to 25% comes from a whole laundry list of other biological sources.
It does, yeah.
I'm looking at this list from the source material, and it's wild. It lists meconium, cytochrome, glutathione peroxidase, catalase, myoglobin, nitric oxide synthase, and ineffective erythropoiesis.
It's a mouthful.
Wait, hold on. You're saying 25% of this toxin comes from things like cytochromes? Aren't cytochromes required for, like, basic cellular energy?
They absolutely are.
Are you telling me the fundamental act of a cell generating energy contributes to a potentially brain-damaging waste product?
That is exactly what is happening, yeah. That dense biochemical list represents various heme-containing proteins and cellular processes scattered throughout the entire body.
Wow.
Take myoglobin, for example. It's the oxygen-binding protein in muscle tissue. Every single time a muscle cell turns over, heme is released.
Just from normal muscle activity.
Right, and cytochromes are indeed essential for cellular energy production in the mitochondria. Glutathione peroxidase and catalase, those are vital enzymes that protect our cells from oxidative damage. Nitric oxide synthase is a crucial enzyme for cellular signaling and blood vessel dilation.
Okay, what was that last one? Ineffective erythropoiesis.
Ah, yeah. That refers to the red blood cells that the bone marrow accidentally manufactures incorrectly. Basically, they are destroyed before they even make it out into the bloodstream.
So literally just existing, having muscles, making energy, communicating between cells, making mistakes in the bone marrow, all of that generates this heme waste.
Precisely. The degradation of all these various heme proteins across every single tissue in the newborn's body contributes that remaining 20 to 25% of the bilirubin load. It's inescapable.
Okay, so we have all this raw heme waste from red blood cells and basic cellular functions. How does it actually turn into the yellow toxin?
The biochemical assembly line for this is a highly specific two-step process involving two distinct enzymes.
Okay, what are they?
First, you have heme oxygenase, and then you have biliverdin reductase. And the crucial detail here for clinicians is that heme oxygenase is the rate-limiting step.
The rate-limiting step, what does that actually mean in this context?
In biochemistry, the rate-limiting step is the ultimate bottleneck. It is the slowest, most restricted step in a metabolic pathway. It basically dictates the overall maximum speed at which the entire assembly line can operate.
Okay, so this entire process starts in the reticuloendothelial system, right? Which is the body's security and cleanup network, primarily located in the spleen, bone marrow, and liver.
Exactly.
Let's trace the exact pathway. We start in that reticuloendothelial system. You have an early peak of waste coming from that ineffective erythropoiesis in the bone marrow we just talked about.
Yep.
And the catabolism, the breakdown of effete worn-out red blood cells and tissue heme in the liver.
Right. So the heme oxygenase enzyme grabs that heme. It takes that 75% from hemoglobin and the 25% from tissue heme, and it converts it into a green pigment called biliverdin.
Okay, green pigment.
Yeah, and the moment that happens, the second enzyme, biliverdin reductase, swoops in and instantly converts that green biliverdin into bilirubin.
But this newly minted bilirubin is highly toxic, right?
Heck.
Like it's fat-soluble or lipophilic.
Highly lipophilic, yes.
If it just floated freely in the blood, wouldn't it instantly melt into the fat tissues in the brain?
It absolutely would. That is exactly why it must travel through the blood plasma, tightly bound to a protein called serum albumin.
Okay, so think of albumin as like the armored transport truck for this toxic waste.
I love that. Armored transport truck.
It secures the fat-soluble bilirubin so it can't seep into the brain, and it carries it safely through the bloodstream directly to the liver.
Perfect analogy. And when that armored truck arrives at the liver, the bilirubin has to be transported into the liver cells, which are known as hepatocytes.
Right.
But it can't just walk in the front door. It has to bind to specialized uptake proteins called ligandins, specifically ligandins J, Y, and Z.
So if the albumin is the transport truck, the ligandins are the loading dock workers pulling the waste into the factory.
Yes.
And the capacity of the factory depends on them, right? Because the uptake of bilirubin actually increases as the concentration of these ligandins increases.
Exactly. The more workers on the dock, the faster you can unload the trucks. Once the ligandins secure the bilirubin inside the liver cell, they haul it deep inside to the smooth endoplasmic reticulum.
The smooth ER.
Right. This is where the actual chemical treatment plant is located.
And the goal of this treatment plant is a process called conjugation.
Conjugation, yes.
The liver has to take this toxic, fat-soluble waste and perform chemical alchemy to turn it into something water-soluble or hydrophilic. Because obviously, if it's not water-soluble, you can't pee or poop it out.
Precisely. That chemical alchemy is catalyzed by a profoundly important enzyme called uridine diphosphoglucuronol transferase. We usually just abbreviate it as UDPGT.
Yeah, I definitely prefer UDPGT.
It saves a lot of time. So UDPGT's entire job is to take the toxic, unconjugated bilirubin and physically attach a sugar acid to it, specifically glucuronic acid.
Okay.
First, it forms bilirubin monoglucuronide, which gets secreted into the bile. Then it continues the process to form bilirubin diglucuronide in the bile ducts and the gallbladder.
So by attaching these water-loving sugar molecules, the toxic fat-soluble bilirubin is permanently transformed into conjugated bilirubin, which is highly water-soluble.
Right. It is finally safe.
But here's where the biology feels almost cruel. UDPGT activity is incredibly low at birth.
Extremely low.
The sources note that it doesn't reach normal adult values until the baby is like 4 to 8 weeks old.
Yep.
If our primary chemical treatment plant takes up to 2 months to fully come online, aren't all babies effectively operating with a massively backlogged factory from the very minute they're born?
They absolutely are. It represents a really fascinating evolutionary puzzle.
How so?
Well, while the fetus is growing in the womb, it actually doesn't need its own liver to process bilirubin.
Right.
The baby's unconjugated fat-soluble bilirubin easily slips straight across the placenta into the mother's bloodstream.
Okay.
And the mother's fully mature UDPGT enzyme conjugates it for them. The fetal liver is intentionally dormant because the mom is doing all the heavy lifting.
But the exact second the umbilical cord is cut.
Exactly. The second it's cut, that baby's liver is suddenly forced to handle a massive load of toxic waste using an enzyme system that is profoundly immature.
Wow. Okay, so the factory is really slow to start, but eventually the UDPGT manages to churn out some of this safe, water-soluble, conjugated bilirubin. You'd think the danger is over once it's safe.
You would think so, but no.
Because for a newborn, the disposal route has a treacherous trapdoor built right into it. Let's trace where that newly conjugated safe bilirubin goes next.
Right. So it is actively excreted by the liver into the biliary canaliculi, which are just the tiny bile ducts, and is eventually discharged into the second part of the duodenum, which is the very beginning of the small intestine.
Once it hits the gut, the intestinal flora, the bacteria living in the baby's digestive tract, they go to work on it.
They do.
They degrade this conjugated bilirubin into 2 new substances, urobilinogen, which accounts for about 10%, and stercobilinogen, which makes up the other 90%.
And this is where we actually see the physical, visual evidence of the entire metabolic process happening.
Oh, really?
Yeah. The stercobilinogen is further oxidized to produce stercobilin. Stercobilin is the exact pigment that gives human feces its characteristic brown color.
That's incredible. So when a parent is changing a diaper and sees the transition from that sticky black meconium to regular brown poop,
They are witnessing the successful microbial degradation of bilirubin in real time.
that's amazing. And what about the remaining 10%?
The urobilinogen is reabsorbed from the gut back into the bloodstream, travels over to the kidneys, and is removed in the urine as a substance called urobilin. Urobilin is what gives urine its amber color.
Okay, but here's the trapdoor. While this waste is just sitting in the proximal small intestine waiting to be pooped out, a process called deconjugation occurs.
Yes, the dangerous loop.
An enzyme located in the brush border of the baby's intestine, called beta-glucuronidase, actually attacks the safe bilirubin. It strips away the glucuronic acid that the liver worked so hard to attach, reverting the safe conjugated bilirubin back into the toxic, unconjugated, fat-soluble form.
It undoes all the liver's hard work. And because it is fat-soluble again, it easily slips right back through the intestinal wall, re-enters the bloodstream, and forces the liver to start the entire process over again.
It's just endless.
This endless loop, the uptake, conjugation, excretion, deconjugation, and reabsorption, is called the enterohepatic circulation.
It's like the liver painstakingly packed the toxic waste into a waterproof container and sent it down the river to be flushed out. But because the river is moving too slowly, an enzyme on the riverbank actually cuts the container open, dissolving the waste back into the water where it seeps right back into the soil.
That is a brilliant way to conceptualize it, the container being cut open.
Yeah.
And you hit on the critical variable there, the speed of the river.
The intestinal transit time.
Exactly. The enterohepatic circulation is exceptionally extensive in neonates precisely because nutrient intake is very limited in the first few days of life. When a newborn isn't drinking large volumes of milk, their intestinal transit time is prolonged.
The bowels just move at a crawl.
Right. And this slow river gives the beta-glucuronidase enzyme on the brush border hours and hours to cut those containers open and send the toxic bilirubin back into the baby's blood.
So with this precarious recycling loop in mind, the immature UDPGT factory, the understaffed ligand and loading docks, the high red blood cell turnover, and the slow river of the gut, we can now distinguish between a system that is just a bit slow to start and one that is dangerously malfunctioning.
Yes, that distinction is everything.
How does a clinician look at a yellow baby and know if it's a normal backlog or a catastrophic crisis?
That brings us to the most vital clinical distinction in neonatology, separating physiologic jaundice from pathologic jaundice.
Let's examine the mechanics of physiologic jaundice first.
Sure. Physiologic jaundice is essentially a perfect storm of all the normal newborn biology we just discussed. First, you have an increased bilirubin load. Newborns naturally have a higher red blood cell mass than adults, and those red blood cells have a significantly shorter lifespan, which leads to accelerated destruction.
Add to that the ineffective erythropoiesis we mentioned earlier, the bone marrow making mistakes and destroying cells before they even launch.
Exactly. Massive raw material production. Second, you have a decreased excretory capacity. The liver's uptake is slow because of low ligandin levels.
The loading dock is understaffed.
Right. Third, the chemical treatment plan itself is slow because UDPGT activity is incredibly low. And finally, you compound all of that with an enhanced enterohepatic circulation. The newborn gut has very few bacteria to safely break down the bilirubin into stercobilin, but it has highly active beta-glucuronidase opening the waterproof containers and sending the toxin back.
When you lay it out like that, honestly, it's a miracle. Only 60 to 80% of babies turn yellow. It feels like the whole system is just designed to fail.
It really does. And because of this, the clinical criteria for diagnosing normal physiologic jaundice are incredibly strict. First and foremost, it is a diagnosis of exclusion.
A diagnosis of exclusion. Let's underline that.
I cannot emphasize that phrase enough. A diagnosis of exclusion means a clinician is never allowed to look at a yellow newborn and simply assume it is normal physiologic backlog.
You can't just guess.
Never. They must actively investigate and rule out every single dangerous pathological cause first. You only arrive at the comforting diagnosis of physiologic jaundice when every other terrifying possibility has been eliminated.
Okay, let me make sure I'm getting the math right here. Because the timing parameters from the sources are really rigid. Physiologic jaundice is not seen earlier than 24 hours. The onset must be at or after 36 hours of life.
Yes, the timing of onset is the ultimate differentiator. A healthy liver, even a profoundly immature one, takes a little time to get overwhelmed by the normal backlog. If a baby turns yellow in the first 24 hours...
The factory isn't just slow to start.
Exactly. The house is actively on fire. The red blood cells are being destroyed at an unnatural, catastrophic rate.
The rate of the rise in serum bilirubin is also carefully tracked, right?
It is.
For physiologic jaundice, the rise must be less than or equal to 5 milligrams per deciliter per day, or less than 0.5 milligrams per deciliter per hour.
Right. If it's climbing faster than half a milligram an hour, the liver's immaturity alone cannot explain it. Something is actively bursting red blood cells open.
The peak levels and durations also have strict ceilings. In a term infant, physiologic jaundice should peak at no more than 12.0 milligrams per deciliter between days 3 and 5, and it should resolve within 7 days.
Correct.
And in a preterm infant, because their system is even more immature, it is allowed to peak at 15.0 milligrams per deciliter around day 7, and it can last for 12 to 14 days.
Yep, that's the standard timeline. And there's one more crucial parameter. For physiologic jaundice, the direct bilirubin, which is the conjugated water-soluble portion, must be less than 2 milligrams per deciliter, or less than 20% of the total serum bilirubin.
Why is that distinction so vital?
Well, if the direct bilirubin is high, it means the UDPGT factory successfully conjugated the waste, but something is physically blocking it from leaving the liver or the gallbladder. Oh, like a plumbing issue.
Exactly. That implies a completely different, very serious anatomical or mechanical problem, like biliary atresia. It completely rules out normal physiologic backlog.
Okay, so if a baby fits perfectly within that tight box onset after 36 hours, slow rise, low peak, short duration, low direct bilirubin, we can comfortably call it physiologic.
Yes.
But what happens when the basic mechanisms are overwhelmed by an external attack or a genetic defect? That is pathologic jaundice.
Pathologic jaundice occurs when an underlying disease process dramatically accelerates the destruction of red blood cells or severely impairs liver function. The criteria for pathologic jaundice are essentially the exact inverse of the physiologic rules we just discussed.
Let's run through them. It is pathologic if the onset is before 36 hours of age.
Right.
If the rise in serum bilirubin levels is greater than 0.5 milligrams per deciliter per hour or greater than 5 milligrams per deciliter per day.
Again, that rapid, aggressive rise is the hallmark of active hemolysis, red blood cells bursting open in real time. It's pathologic if the serum bilirubin exceeds 12.9 in a term infant or 15 in a preterm infant. If the direct bilirubin is greater than 1.5 to 2 milligrams per deciliter, if the jaundice persists beyond 10 to 12 days in a term infant, or 14 days in a premature infant.
Yes, all of those.
And crucially, the absolute red flag, any jaundice in a sick child is considered pathologic.
That last point dictates immediate action. If the baby has a fever, is lethargic, or isn't feeding well, the jaundice is no longer considered a harmless backlog.
It's not just a slow river anymore.
No. It is a symptom of a severe systemic illness, most likely sepsis, until proven otherwise. The stakes are simply too high. Because the end result of uncontrolled pathological jaundice is kernicterus and permanent brain damage, a clinician treats every rapidly rising or early onset case as a neurological emergency.
So if a pediatrician is staring at a pathological case, the house is on fire, they need to know exactly who started the fire. The clinical protocol specifically outlined common causes of jaundice in the tropics, which introduces a really fascinating geographical layer to the detective work.
Geography heavily influences the differential diagnosis. In tropical regions, the common causes are predominantly hemolytic.
Meaning they destroy red blood cells.
Right. The primary suspects are G6PD deficiency, bacterial sepsis, specifically involving hemolysins, which are bacterial toxins that destroy red blood cells, ABO blood group incompatibility, low birth weight and prematurity, and rhesus, or Rh hemolytic disease.
Let's unpack these blood incompatibilities because the underlying mechanics between ABO and Rh are wildly different. Let's start with ABO incompatibility.
Okay.
This occurs when there is a blood group clash between the mother and the child, specifically when the mother is blood group O and the baby is blood group A or B.
The key to understanding ABO incompatibility is recognizing that a person with type O blood naturally inherently possesses anti-A and anti-B antibodies in their bloodstream. It is a baseline physiological fact.
So they don't need a prior exposure.
No, the mother does not need to be exposed to type A or type B blood to develop them. Her immune system naturally produces them from early in life.
So there is no need for what they call pre-sensitization. The weapons are already manufactured and circulating.
Exactly.
If some of those naturally occurring anti-A or anti-B antibodies slip across the placenta during pregnancy, and the baby happens to be type A or type B, those maternal antibodies will immediately recognize the baby's red blood cells as foreign invaders.
They lock on and attack, causing immediate hemolysis.
Wow.
The attack breaks open millions of the baby's red blood cells, releasing massive amounts of hemoglobin. That hemoglobin is rapidly converted by Ham oxygenase into bilirubin, instantly overwhelming the newborn's immature liver factory. Now, contrast that immediate natural clash with Rh incompatibility.
Right. Rh incompatibility happens when the mother is Rh negative and the baby is Rh positive. But unlike the ABO scenario, an Rh negative mother does not naturally possess antibodies against Rh positive blood.
Yeah.
She has to be sensitized.
Yes, her immune system is entirely naive to the Rh positive protein. The only way she will build an army of anti-Rh antibodies is if she is physically exposed to Rh positive blood.
How does that happen?
This typically happens during a previous pregnancy, a miscarriage, or the delivery of an Rh positive baby, where a small amount of the baby's blood mixes into her circulation.
So during that first exposure, her immune system detects the Rh positive blood, realizes it's foreign, and slowly starts building antibodies. The first baby is usually perfectly fine because it takes weeks or months to build that army, right?
That's usually the case, yes. But from that moment on, she is presensitized. She harbors these anti-Rh positive antibodies forever.
The trap is set.
Precisely. On re-exposure, meaning during a subsequent pregnancy with another Rh positive baby, those preformed anti-Rh antibodies act with terrifying speed.
Because the army is already waiting.
Yes. They cross the placenta and mount a massive coordinated attack on the new baby's red blood cells while it is still in the womb. This results in severe hemolytic disease of the newborn, leading to extreme, dangerous levels of jaundice that often present within minutes or hours of birth.
That perfectly explains why RH requires a first exposure to build the army, while ABO is an immediate clash of naturally occurring forces. But beyond genetics, the protocols also list some uncommon physical causes of jaundice, and this is where the biology gets really visceral.
It does.
They list extravasated blood, specifically cephalohematomas, and extensive bruising, perhaps from a breech delivery. Wait, a bruise on the baby's head can directly cause their skin to turn yellow days later.
It is a profound example of the body's recycling system being overwhelmed by trauma. Extravasated blood is simply blood that has leaked outside of the blood vessels and is trapped in the surrounding tissue.
Okay.
A cephalohematoma is a large collection of blood trapped under the scalp, usually resulting from intense pressure during a difficult vaginal delivery. Extensive bruising is the same mechanism on a larger surface area.
So the body is literally recycling the bruise. The blood trapped in that cephalohematoma is outside the normal circulation. The body recognizes it as dead tissue and sends the reticuloendothelial system to break it down.
Exactly. As those millions of trapped red blood cells degrade in the tissue, they release immense amounts of heme all at once. This massively spikes the bilirubin load hitting the liver, completely independent of the normal daily red blood cell turnover.
It's an internal hemorrhage being slowly digested and converted directly into bilirubin.
That's exactly what it is.
The clinical notes also mention starvation and dehydration as uncommon causes, which seamlessly ties into one of the most common external factors clinicians must navigate, the feeding conundrum.
Ah, yes. Feeding.
While genetics and birth trauma are internal battles, the external input of nutrition profoundly dictates how the bilirubin pathway functions. Let's rigorously distinguish between breastfeeding jaundice and breast milk jaundice because they sound identical but have entirely different mechanisms.
Distinguishing between the two is critical for a clinician. Let's start with breastfeeding jaundice. The mechanism here is entirely mechanical. It is a volume problem.
A volume problem. Okay.
It is characterized by an early onset, typically between 2 and 4 days of life, and it is strictly caused by inadequate breastfeeding.
So if we go back to our slow river metaphor, the enterohepatic circulation, breastfeeding jaundice is what happens when the river completely dries up.
Perfect analogy, yes.
When a baby has a poor latch or the mother's milk hasn't fully come in yet, there is a lack of fluid volume in the digestive tract. This inadequate feeding drastically reduces intestinal motility.
The bowels just stop moving.
Yeah.
You have profound stasis of bilirubin. The conjugated safe bilirubin is just sitting completely stagnant in the gut.
And because it's just sitting there.
It gives that beta-glucuronidase enzyme unlimited time to systematically deconjugate all of it. The safe bilirubin is stripped of its glucuronic acid, turns back into a fat-soluble toxin, and is reabsorbed straight back into the blood.
So breastfeeding jaundice is a lack of milk causing the conveyor belt to stop, allowing the gut enzymes to throw the trash back into the house. Breast milk jaundice, on the other hand, is completely different. The protocols note that it is rare, and it isn't a mechanical volume problem. It is a biochemical sabotage.
Precisely. Breast milk jaundice is caused by the actual presence of certain substances deeply embedded within some mother's breast milk. These substances actively, chemically inhibit the action of the baby's UDPGT liver enzyme.
The milk itself contains the saboteur.
It does.
The exact substances identified in the source are high levels of beta-glucuronidase naturally present in the milk, or products of human female hormones, specifically progesterone metabolites.
Yes.
When the baby ingests this milk, these compounds travel directly to the liver and literally unplug the UDPGT machine.
They chemically block conjugation. And the recommended treatment protocol for this acts as both a medical intervention and a brilliant diagnostic test.
What do they do?
The clinician will instruct the mother to temporarily stop breastfeeding and commence formula feeds.
So if it is true breast milk jaundice, the cessation of breastfeeding cuts off the supply of the saboteur. The formula feed flushes the gut, gets the river moving, and removes the inhibitory substances.
And the bilirubin levels will plummet.
And that rapid fall proves the diagnosis.
Exactly. Once you confirm it, the mother can usually recommence breastfeeding. The bilirubin might rise slightly again, but it will not return to the previous dangerous levels because the baby's liver has had a few days to mature and can now overcome the inhibitors.
So if I'm a pediatrician looking at a yellow baby, how on earth do I figure out if it's a normal backlog, a massive head bruise, inadequate feeding, or a catastrophic genetic reaction? What is the actual protocol for that detective work?
This brings us to the management phase, the detective's checklist. The protocols lay out a rigorous mandate for history-taking and investigations.
Let's start with the history.
The clinical history is where the puzzle must be solved. The clinician must meticulously document the exact onset and the severity of the jaundice. Is it before or after 36 hours?
Because that immediately categorizes it as phys or path.
Exactly. They must ask about the baby's behavior. Is the child still sucking well? Is there a history of fever? Is there poor activity or lethargy?
Why are the behavioral questions so critical? Like, why focus on the sucking?
Because poor suck, poor activity, and lethargy are the earliest clinical features of encephalopathy.
Brain damage.
Yes, they are the terrifying signs that the toxic unconjugated bilirubin has already breached the blood-brain barrier and is actively damaging the neurological tissue. It instantly escalates the situation from a biochemical puzzle to a life-or-death neurological emergency.
The clinician also has to rule out the usual suspects like sepsis, Rh incompatibility, and G6PD deficiency. And there is an incredibly specific, terrifying part of the history regarding G6PD that really stands out. The clinician is mandated to ask the parents about the use of icterogenic substances.
Yes, icterogenic simply means causing jaundice. G6PD deficiency is a genetic enzyme defect that leaves red blood cells completely defenseless against oxidative stress.
Okay, so their defense shields are down.
Right. Under normal, everyday conditions, a baby with G6PD deficiency might be perfectly fine and asymptomatic. But if they are exposed to certain specific chemicals, it triggers a catastrophic, explosive breakdown of their red blood cells.
The protocols list these everyday triggers. Sulfonamides, which are a class of antibiotics, naphthalene, which is the active chemical in camphor and mothballs, and mentholated products like over-the-counter vapor rubs.
Yeah.
Wait, are you telling me a well-meaning mother puts a menthol rub on her baby's chest for a sniffle? Or stores the baby's blankets with camphor mothballs and it triggers a cellular explosion?
It is a tragic reality. The oxidative stress induced by inhaling or absorbing naphthalene or menthol rapidly overwhelms the fragile defense mechanisms of the G6PD deficient red blood cells.
It's horrifying.
The cell membranes literally shatter. Millions of cells burst open, pouring massive amounts of heme into the bloodstream in a matter of hours. It transforms a stable, healthy-looking baby into a severe, potentially fatal jaundice case almost overnight. And the parents have absolutely no idea they triggered a hemolytic crisis with a common household item.
It just highlights why asking about peripartum fever, maternal medications, and family history of jaundice is so vital. Once the detailed history provides the clues, the clinician moves to the hard science, the mandatory investigations.
The blood tests are targeted to pinpoint the exact bottleneck. First, total and conjugated bilirubin levels.
You need the exact numbers to know how high the water is rising.
And you need to know what fraction is conjugated to rule out a mechanical blockage in the bile ducts.
Right. Next, they test the blood group of both the baby and the mother to check for that ABO incompatibility. Then the Coombs test. The protocol specify this is to look for autoimmune hemolytic anemia. How does that work?
The Coombs test is a brilliant assay that specifically detects maternal antibodies that are physically stuck to the surface of the baby's red blood cells.
Oh, so it looks for the weapons themselves.
Exactly. If the Coombs test is positive, it is definitive proof that the mother's immune system, like in Rh disease, is actively attacking and destroying the baby's blood.
They also order an FBC, or full blood count, a blood film, to look at the shape of the cells, and, crucially, a reticulocyte count. The notes state that if the red count is elevated, it means a hemolytic process is actively ongoing. What is a reticulocyte and why does it prove hemolysis?
A reticulocyte is an immature, very young red blood cell that has just been freshly released from the bone marrow. Under normal circumstances, you only have a tiny percentage of reticulocytes floating in your blood.
Because they mature quickly.
Exactly. But if your mature red blood cells are being violently destroyed by mothballs or maternal antibodies, the bone marrow panics. It realizes the body is bleeding out internally, so it starts pumping out these young, immature reticulocytes as fast as it possibly can to replace the destroyed cells.
So seeing an elevated reticulocyte count is the ultimate proof that the body is desperately trying to survive active hemolysis.
Yes. It's a distress signal from the bone marrow.
So the investigations confirm the exact numbers. We know the cause. But if the levels fall into the moderate to severe hyperbilirubinemia range, it becomes a literal race against the clock to lower the bilirubin before it crosses into the brain.
It does.
Before machines and blood tests give the exact number, clinicians often use a highly validated visual estimate to gauge the severity. It's called Cramer's rule.
Kramer's rule maps the physical progression of the yellow color down the baby's body, correlating it with an estimated serum bilirubin level. It progresses perfectly head to toe, or cephalocaudal.
It's like a visual dipstick.
Hmm,
If the jaundice is only visible on the head and face, the estimated level is 5 milligrams per deciliter.
right.
If the yellowing extends down to the trunk, the level is approximately 10 milligrams per deciliter.
As the concentration in the blood rises, the bilirubin spills over into tissues further and further from the core. If it reaches the thigh, the estimated level is 15 milligrams per deciliter.
And if the yellowing reaches the sole of the feet.
Then the bilirubin is estimated at a terrifying 20 milligrams per deciliter.
So you look at the feet to know if you are in the danger zone. Once the numbers confirm moderate to severe hyperbilirubinemia, the first line of defense is light. We initiate phototherapy.
Yes, phototherapy.
The protocols indicate phototherapy is used for moderate to severe cases and is also used prophylactically preventatively in preterm infants and cases of Rh isoimmunization, where the clinician just knows a massive spike is imminent.
However, the protocols contain a massive, strictly worded caveat. Phototherapy is not allowed in conjugated hyperbilirubinemia.
Let me underline that. If the direct conjugated bilirubin is high, meaning the bile ducts are blocked, phototherapy is absolutely strictly contraindicated. You cannot use it.
Correct. Exposing a baby with high conjugated bilirubin to phototherapy lights causes a dangerous, highly adverse physical reaction. It is strictly forbidden.
But when it is allowed for unconjugated hyperbilirubinemia, how does shining a light on a baby actually cure a biochemical toxin? What is the mechanism?
It is entirely reliant on the physics of light. Phototherapy utilizes two processes, photooxidation and primarily photosomerization.
Photosomerization.
Yeah, it's a rapid process that physically alters the geometric structure of the bilirubin molecule. The light doesn't chemically digest it, it physically twists it.
The light literally changes the structural shape of the fat-soluble molecule into a completely different water-soluble isomer called lumorubin.
Yes.
It is structural alchemy. And these lumorubin isomers are so easily excreted that the liver doesn't even have to conjugate them. They just bypass the UDP-GD factory entirely and slip out into the bile and urine.
It's brilliant. But you cannot just use a regular household light bulb. The physics require extreme, regulated precision. The protocol specified that the spectrum of light must fall strictly between a wavelength of 450 and 460 nanometers.
Because bilirubin only absorbs light at that highly specific blue-green frequency.
Exactly. The power output matters too. The irradiance or power level must be maintained between 30 and 40 microwatts per square centimeter per nanometer.
And there's a strict Goldilocks zone for how close this specialized light can be to the baby, right?
Yes. The distance between the baby and the phototherapy lamp must not be greater than 50 centimeters, or the light loses its efficacy. To maximize the irradiance, the lamp can be brought as close as 10 to 15 centimeters.
But the clinician must monitor them constantly, because if it gets closer than 10 centimeters, the baby can become hyperthermic, their core temperature rising dangerously high, or they could suffer literal thermal burns from the radiant heat.
It is a highly calculated medical intervention, not just a sun lamp.
But what happens when the light isn't fast enough? If a clinician uses Kramer's rule, looks at the baby's feet, and sees yellow, they know the level is at 20 milligrams per deciliter. Structural alchemy takes time, and at 20, the brain is under immediate existential threat.
When light isn't enough, we have to physically remove the toxic blood from the baby's body.
This brings us to the ultimate extreme reset, the exchange blood transfusion, or EBT.
The EBT.
The protocols dictate that an EBP is the definitive life-saving treatment for very severe cases. The core indication for performing an EBT in term babies is when the unconjugated serum bilirubin reaches or exceeds 20 milligrams per deciliter.
However, the protocols outline several crucial clinical exceptions where a clinician must initiate and exchange blood transfusion even when the SBR is less than 20 milligrams per deciliter.
What are the exceptions?
They are hypoalbuminemia, severe asphyxiated babies, severe neonatal sepsis, metabolic acidosis, and hypoglycemia.
Let's work through the logic of this. Why do these specific conditions lower the threshold for such an extreme, invasive procedure? The notes state that these conditions may impair the blood-brain barrier, increasing the tendency of bilirubin to enter the brain and cause kernicterus.
It's all about the integrity of the baby's biological shields. Think about hypoalbuminemia, low albumin. We established that albumin is the armored transport truck.
Right.
If a baby has low albumin, there aren't enough trucks. The bilirubin floats freely as an unconjugated, fat-soluble toxin, perfectly primed to slip into the brain. You can't wait for the level to hit 20. The free toxin is already a threat at lower levels.
And conditions like severe asphyxia, a lack of oxygen at birth, or metabolic acidosis or hypoglycemia, these all cause massive systemic physiological stress.
Exactly. That severe stress fundamentally damages the cellular integrity of the blood-brain barrier. Normally, the barrier is a tight, impenetrable fortress against toxins, but asphyxia, acidosis, and low blood sugar cause the tight junctions of the barrier to become leaky.
They literally open a back door into the brain tissue.
Yes. If a baby's shield is down, a bilirubin level of 15 or 16 might be just as deadly as a level of 25 in a healthy baby. You must intervene early.
For preterm babies, calculating the threshold for an EBT requires a different formula because their brains are inherently more fragile. The protocols provide a profoundly elegant medical shortcut known as the Rule of 10.
The Rule of 10 beautifully simplifies a complex physiological decision in the middle of an emergency. To determine the exact bilirubin threshold for performing an exchange blood transfusion on a premature infant, you simply multiply the baby's weight in kilograms by 10.
The protocols give clear examples. For a tiny 1 kilogram baby, you multiply 1 by 10. The EBT threshold is 10 milligrams per deciliter. If the bilirubin hits 10, you do the transfusion.
Right.
For a slightly larger 1.1 kilogram baby, 1.1 times 10 is 11. The threshold is 11 milligrams per deciliter.
It is a brilliant, life-saving mental shortcut. It perfectly scales the extreme intervention to the exact size and physiological fragility of the infant.
So put yourselves in the shoes of a clinician at 3 a.m. The baby's level has crossed the threshold. The decision is made to perform an exchange blood transfusion. How is it actually done? The protocols describe it as a procedure that enables the quick reduction of bilirubin through a push-pull process.
The visceral reality of this procedure is intense. It involves the sequential removal and transfusion of tiny, meticulously measured aliquots or volumes of blood. The easiest and most direct access point for this procedure is through the umbilical vein.
You are literally using the remnant of their maternal connection, the umbilical cord, to manually pull out their toxic blood, throw it away, and push in fresh, clean donor blood.
This push-pull process achieves several life-saving goals simultaneously. Primarily, it physically removes the bilirubin-saturated blood. Second, it flushes out toxic substances like the bacterial hemolysins circulating during severe sepsis.
That makes sense.
Third, in cases of Rh or ABO incompatibility, it actively extracts the maternal antibodies that are hunting the baby's cells, as well as the antibody-coated red blood cells that are destined to burst. And finally, by pushing in healthy donor red blood cells, it immediately corrects the profound anemia caused by the hemolysis.
But the precision required is terrifying. You can't just drain a baby's blood and refill them. The protocols detail the exact syringe sizes used for these small aliquots to prevent hemodynamic shock. If you pull too much blood out at once, the baby's blood pressure crashes and their heart stops.
The volumes are incredibly small. For preterm babies, the clinician uses a 5 milliliter syringe. For term babies, a 10 milliliter syringe. And for older babies, a 20 milliliter syringe.
You are standing over a fragile 1 kilogram infant, manually pulling out 5 milliliters of toxic blood, discarding it, and gently pushing in 5 milliliters of donor blood, over and over and over again. The protocols state the process takes 60 to 90 minutes.
It is the ultimate physiological high-wire act. You are slowly replacing the entire fluid volume of a tiny human being without destabilizing their fragile cardiovascular system.
The math behind the total volume swapped is strictly defined. The clinician performs what is called a double volume exchange. They calculate the exchange volume by multiplying the baby's estimated blood volume by 2.
Replacing the entire blood volume twice ensures a massive mathematical washout. It guarantees that roughly 85% of the baby's original toxic blood is successfully replaced with clean donor blood.
That's a huge turnover.
It is. The protocol mandates taking blood samples immediately before and after the 90-minute procedure to biochemically confirm the catastrophic drop in bilirubin levels.
But because an exchange blood transfusion is such an invasive, extreme procedure, it has strict contraindications. It absolutely cannot be done on a very ill child whose cardiovascular system simply might not survive the fluid shifts.
And even when executed perfectly, it carries severe, life-altering complications. The immediate risk is NEC, or necrotizing enterocolitis. That's a devastating disease where portions of the baby's bowel undergo tissue death due to the blood pressure fluctuations.
Oh, wow.
A late complication can be liver cirrhosis, permanent scarring of the liver resulting from the massive stress and potential silent infections associated with major blood product transfusions.
Because the risks of EBT are so extreme, clinicians will also employ pharmacotherapy drugs to help manage the bilirubin, though the protocols explicitly warn that these yield very slow results. They are not an acute fix for a baby rapidly approaching the 20 milligram per deciliter danger zone.
Pharmacotherapy is a supportive intervention designed to target the specific biochemical bottlenecks we mapped out earlier. The primary drug listed is phenobarbital.
Phenobarbital is typically known as an old anti-seizure medication, but here the protocols state it is used as an enzyme inducer.
Yes. Administering phenobarbital acts directly on the liver to induce or wake up the dormant UDPGT factory. It chemically forces the immature liver to rapidly synthesize and increase its production of the conjugated enzyme, accelerating the body's natural ability to process the bilirubin backlog.
The protocols also list albumin administration, which makes perfect sense based on our armored truck analogy. If the baby has low albumin, giving them intravenous albumin provides a fleet of empty transport trucks to bind the free, fat-soluble bilirubin, locking it up so it cannot cross into the brain.
Exactly. The protocols also mention IVIGA intravenous immunoglobulins. In cases of immune incompatibility, flooding the baby's system with these donor antibodies can help block the mother's antibodies from attaching to and destroying the baby's red blood cells.
And finally, they list mesoporphyrin.
Right.
Mesoporphyrin is fascinating because it targets the very beginning of the assembly line. It is a specialized drug that directly inhibits heme oxygenase, that critical rate-limiting enzyme that converts heme to biliverdin.
It shuts down the factory at the source. It is incredible how every single pharmaceutical intervention, waking up UDPGT, adding albumin trucks, blocking antibodies, inhibiting heme oxygenase, directly targets a specific physiological vulnerability we mapped out in the metabolism pathway.
It demonstrates how a deep cellular understanding of biology translates directly into targeted, life-saving clinical management.
It really does.
And with that, we've traced the entire astonishing journey, from the very source of the yellow hue, the unavoidable breakdown of hemoglobin and cellular cytochromes, through the liver's delayed UDPGT factory, right down the treacherous, slow-moving river of the intrahepatic circulation.
We've explored the rigorous detective work required to distinguish a normal physiologic backlog from a rapidly destructive pathologic crisis. We've seen how a clinician must navigate the geographic variables of the tropics, the immediate clash of ABO incompatibility, and the hidden dangers of household camphor triggering a G6PD cellular explosion.
We looked at the exact physics of phototherapy, using 450 nanometer light to perform structural alchemy on a toxic molecule, and the terrifying, life-saving arithmetic of the rule of 10 and exchange transfusions, pulling out the danger 5 milliliters at a time. This deep dive armors you with a total understanding of the incredible high-wire act clinicians perform to safely navigate neonatal jaundice.
And as we conclude, I want to leave you with a final thought to mull over. We've spent this entire time focused on the profound neurological toxicity of bilirubin and the heroic medical measures required to clear it from the newborn's body.
Right.
But consider this. If the newborn body actively relies on an extensive enterohepatic circulation that deliberately, enzymatically pumps bilirubin back into the bloodstream, and if this precise sequence of events happens to 80% of all premature babies, could it be that mild levels of bilirubin, despite being so dangerous at high concentrations, actually serve a vital evolutionary purpose?
Wait, really?
Bilirubin is known to be a powerful systemic antioxidant. Perhaps the baby's body is intentionally retaining it to protect its fragile, newly born tissues from the sudden, highly oxygen-rich environment of the outside world. It flips the whole concept of bilirubin as a mere waste product completely on its head.
That is a profound way to look at it. Thank you for joining us on this intricate, high-stakes biological journey. We hope this deep dive has given you a completely new perspective on a condition that is as common as it is complex. See you on the next one.